The corridors are bare, ballrooms filled with empty chairs. This may seem strange, but good to know that some things never change. So grab a seat, kick up your feet, and let's get started.
Hi, everyone. Craig Buckman coming to you here from St. Louis, Missouri. Welcome to the Fall American Neurotology Society meetings and the study groups. As you all know, we decided to use Whova this year for our app to run the meeting because of its many functionalities that it provides. The key aspects of Whova are that the tabs there on the left side of your screen help you find your way around the app. These include things like the agenda, attendees, community, and other things. Please take a few minutes during these 2 days to explore those different tabs. Please visit the sponsor tab, as each of these sponsors has created some materials for you to see. Thanks to Advanced Bionics, Cochlear, Med-El, and Oticon for sponsoring our meeting and for their continued support of the ANS and our mission. Importantly, the agenda tab will drop you into the meeting sections, as many of you who are here already know. You'll need to go back to that agenda tab each time we move forward to a new section. So after the section's done, close out of that one and then move on to the next. On the right side, you'll see the Q&A tab, as well as the chat tab. If you want to ask a question, then go into the Q&A tab and put the individual's name that you want to ask the question of, as well as the question, and then our moderators will pick that up and drop it to the speakers during the Q&A session. So with that, I hope everyone has a great meeting. Let's get this party started. First up is the Third Window Study Group, led by Jerry Gianoli and John Carey. So thanks to you all.
Hello, everyone.
Hey, everybody.
As you heard, we'll be monitoring questions coming in through the Whova platform, so please put questions as we go, and welcome to our third mobile window study group. We have a great program lined up. We're going to take 3 presentations and then Q&A, and then the final 3 and Q&A after that. Jerry, you want to introduce our first speaker?
Sir, our first speaker, and just to alert everyone, the first speaker is actually pre-recorded, so he will not be available for questions afterwards, so don't bombard him with questions. But it's David Freeland, and it's acute onset otalgia and pulsatile tinnitus. It is of a unique presentation of a carotid cochlear dehiscence. So I guess we can roll tape at this point.
I'd like to thank you for the opportunity to present, and sorry I could not be there live, but I appreciate the accommodation to record this ahead of time. I thought I'd present an interesting case of third mobile window. Maybe it doesn't have all the symptoms of a classic third mobile window, but it certainly is an abnormal entry into the inner ear. And this is a patient who initially presented with a chief complaint of right pulsatile tinnitus. So around December of last year, she started to develop some right ear fullness. She said she tried over-the-counter decongestant and the fullness went down, but then it recurred. She started to get occasional sharp pains in the ear and a clogged feeling. She kept taking decongestant. A couple of months later, she had a day where she had a sudden, sharp, intense pain in the right ear. She described it as the worst pain ever. The sharp, intense pain resolved, and she was left with a constant throbbing sensation in her right ear. She also noticed she was hearing her pulse, particularly at night when it was more quiet. She had a vague sensation of dizziness. It was not vertigo, and she did have notable anxiety regarding these ear symptoms. Given that this was localizing to the right ear and associated with pain, I did recommend we obtain a CT scan of the temporal bones. But first, we did some audiometric testing. On evaluation, the tympanic membranes were clear, but she had a prominent anterior canal wall hump, and I could not see the anterior inferior tympanum. There was no audible bruit or pulsation. Her audiogram was normal, and for this group in particular, there was no pseudoconductive low-frequency hearing loss that you typically see with a mobile third window. Her tympanometry is displayed to the right. You can see it's a type A tympanogram, but it does have that unusual notch in the mid portion. I did not make much of it at that time, but in retrospect, given the vascular nature of this presentation, I wonder if we were catching a pulsatile beat in the middle of the tympanogram. So as I mentioned, I recommended a CT of the temporal bones, and these are two sequential axial images of her right temporal bone. And you can see the basal turn of the cochlea, and you can see this carotid dehiscent into the hypotympanum and into the cochlea. And that was located on her right side only. If we look at the coronals, you can see the cochlea and this pseudoaneurysm of the petrous carotid into the hypotympanum. And here, and more toward the basal turn, you can see that dehiscence into her cochlea. So I referred and consulted with our neurovascular surgeon. He performed a CT angiogram demonstrating a pseudoaneurysm. And we decided to present this at neurovascular conference because the question was, should this be approached externally, trying to either move or pack the carotid away from that area, or was there an endovascular option? And the committee ultimately recommended an endovascular stent, and she did undergo that placement of a stent across that dehiscence. So here is a reformat in the plane of the carotid, and you can see how it comes up to where it was dehiscent into the cochlea, and there's a fairly long stent, and in fact this stent is much longer than this. I'll show that shortly, but it does bridge the area of the turn of the petrous carotid right where the dehiscence was. If we look again at the axial and coronal scans I showed before, but this time with the stent in place, you can see the pseudoaneurysm is bypassed and the area of the dehiscence is likewise bypassed. This here is a video screen coming from superior to inferior as it passes through the carotid. And this gives a sense of how it passes by the area of dehiscence and how long this stent actually is. Here's our temporal bone, and our cochlea is coming into view here. And you can see the stent passing the basal turn of the cochlea and then going down into the neck. So she just recently followed up with neurosurgery. Her pulsing sensation has resolved. The pulsatile tinnitus has resolved. Her dizziness has resolved. She has a low-grade ache in the ear, and she noted she perceived some decline in hearing, so we do have a follow-up audiogram pending. So this is not a classic third mobile in the sense of many of the other types of symptoms that we see in superior canal dehiscence, but this does involve the pulsatile tinnitus, which is a form of autophony. And I thought this was interesting because of the acute onset of the pain, and that raises for me a question that she had a sudden breaking of the bone or the mucosa in the hypotympanum, leading to this acute symptom. I do also wonder if whether the chronic use of decongestants such as Sudafed raised her blood pressure and contributed to either accelerating this process or causing this process. But through an endovascular approach, this was able to be rectified. And so this I thought was an interesting, unusual case that would provide some interest to our group. And so thank you for the opportunity to present, and I hope you enjoy the rest of the meeting.
Well, that was unusual and very interesting. Sorry we can't have David here for questions, but we're going to move on to our second presentation, and that's going to be Dr. Behrooz Amirzagar from Iran on coating capsule dehiscence on CT.
John, we cannot hear Behruz. Can you just check with him to see if his audio is working? We're not hearing him.
Not just audio is hearing him.
Neil, should we move on and come back to him?
Hello, everybody.
Move on,
Here we go.
and come.
Well, it looks like we're having technical difficulties getting his audio feed. So why don't we go to our next presentation and see if we can work that out. That's going to be Dr. Jacob Fisher, disambiguating concurrent SCD and PCD.
Okay, good afternoon. My name is Jacob Lewis Fisher. I am a chief resident at Walter National Military Medical Center. And today I'm going to be presenting on behalf of myself and Dr. Tolosano, an interesting case of a patient with multiple semicircular canal dehiscencies. I have no disclosures or conflicts of interest to disclose. Our patient was a 45-year-old male who has had a history of multiple blast exposures, traumatic brain injuries, and migraines in the setting of a military service. He presented to the ENT clinic with severe, brief episodes of noise and pressure-induced vertigo, and he had the sensation very frequently that he was hearing his own heartbeat and internal body sounds in his right ear particularly. He found these symptoms overall very disruptive to his daily quality of life, ability to sort of perform normal functions, ability to work out, items like that. On examination, he had a normal otoscopic exam. His Weber did lateralize to the right, but his air conduction is greater than his bone conduction bilateral at a 512 tuning fork. And then when you put a tuning fork 256 on his ankle, he did perceive sounds from his ankle into his right ear. A audiogram was obtained, which demonstrated in the right ear suprathreshold hearing with a airborne gap of about 20 decibels in low frequencies, narrowing to no airborne gap in the higher frequencies. His acoustic reflexes were present bilaterally, and his tympanogram demonstrated normal tympanometry, essentially bilaterally. A CT was obtained. On part A here, we're looking at an axial cut through the right posterior semicircular canal, which demonstrates an area of possible dehiscence posteriorly denoted by the arrow. On part B, this is a Stenver view of that same canal, which demonstrates an area of possible dehiscence versus thinning, again denoted by the arrow. Looking at the remaining semicircular canals, his right superior semicircular canal also demonstrated an area of severe thinning versus dehiscence. And on a postural view of that same canal, which is denoted by part B, there's again severe thinning denoted by the arrow of that superior semicircular canal. On his left side, there was again in the axial cuts a thinning of his left superior semicircular canal, with the postural view of this canal again demonstrating thinning but no frank dehiscence of bone. The remainder of his semicircular canals were non-dehiscent normal bone cortical covering throughout. Given these findings on CT scan, we decided to obtain vestibular testing for this patient. His VEMPs particularly demonstrated evidence of a third window with noted elevated amplitudes and decreased thresholds, particularly noted in the right ear, although the OVEMPs were noted to be abnormal in both ears. So thus far, we have a 45-year-old male who has evidence of right posterior semicircular canal dehiscence and likely right superior semicircular canal dehiscence on imaging, with VEMP testing that was concordant to these findings. We discussed with the patient what his treatment options were. Obviously, option one would be observation. However, the patient found these symptoms to be very disruptive to his daily life, daily activities, and he was very passionate that a surgical intervention needed to be performed of some kind to alleviate these symptoms. when discussing surgery with him, there were a couple options we discussed. First was going to be a transmastoid approach to the posterior semicircular canal, plus or minus on a superior semicircular canal on that right side. That's versus a simultaneously transmastoid and middle fossa craniotomy approach to that. In the end, we decided to start with just this posterior semicircular canal. It was the most apparently dehiscent on imaging, and the morbidity of deciding to go for that sole canal as an approach was relatively low compared to performing the middle fossa craniotomy approach versus adding superior semicircular canal approach to the transmastoid approach. These are intraoperative photos. There is a, with arrows denoting normal anatomy. The pick that you see underneath is denoting the actual dehiscence to that posterior semicircular canal. Was readily apparent, and we were able to identify that through the transmastoid approach relatively simply. We ended up plugging that posterior canal, as denoted in that left image, with pericranium from the periosteum of the pericranium, essentially, and then we filled the remainder of the defect with a combination of bone hete and fibrin glue, which is denoted by the right image. In terms of this patient's recovery, he did note resolution of his noise and pressure-induced vertigo, but he has in the recent months developed persistent imbalance in motion sensitivity since surgery, most consistent with a P3D-like presentation. We did obtain VEMP testing as well in the postoperative period to determine if there's any resolution on testing there. And it did note that he did have essentially no evidence of a third window on examination at this point in time. He did have normal calorics as well, and he had symptoms improved. He has since been engaged in vestibular therapy and has recently started venlafaxine for concern of his P3D and is doing better from that aspect. The reason we presented this case and the reason we thought it was interesting is there was multiple points of discussion. The first question being, could superior and posterior semicircular canal dehiscence be reliably differentiated preoperatively with respect to which canals contributed to their symptoms? Would it be reasonable to repair multiple canals at once? For the group, would anyone perform a simultaneous transmastoid and middle fossa approach to repair a posterior and superior semicircular canal dehiscence? And then the other question for him or for us was, what extent does his history of TBI and/or migraines contribute to his incomplete improvement? That concludes the presentation. Hope you guys found this all interesting, and thank you for having us.
Well, thank you for that interesting presentation. I guess since we only have one paper presented so far, we'll continue with the presentations, and hopefully Dr. Armesarger will be able to present his at the end of the presentation. Next, we have facial nerve neoplasm causing cochlear facial dehiscence in third window, being presented by Dr. Benjamin Johnson.
Hi there. Good afternoon. Just want to say thank you for this opportunity to present with this study group. I did want to just highlight my co-authors on this project. That's Dr. Nayate and Dr. Manzoor. And I'm speaking to you from University Hospitals in Cleveland. We can go to the next slide. We have no financial disclosures to disclose. And next slide. So we are presenting here a 6-year-old male who had a history of right-sided sudden onset idiopathic facial nerve paralysis, which occurred 2 months prior to us seeing him in clinic. He was previously treated with both steroid and antiviral therapy and was found to have full recovery of his facial nerve function. But when he presented to clinic with us, he complained of persistent otalgia, pulsatile tinnitus, and otophony. Of those 3 symptoms, he described the otophony as just being completely debilitating. He would describe it as just being unbearable, specifically when eating a bag of chips or something crunchy like that. He denied any vertigo or previous otologic surgery, and exam was essentially normal in clinic, revealing his right facial nerve with a House Brackman grade 1, and then otomicroscopy was without any evidence of disease. We did obtain a dizziness handicap index, which revealed a score of 60, which denotes a severe impairment. What you see here is an audiogram that was obtained upon its initial presentation to our clinic. What this reveals is a mild bilateral high-frequency sensorineural hearing loss, excellent speech recognition scores bilaterally, normal tympanograms, and normal acoustic reflexes. We also obtained some vestibular testing at that time. What you see here is a CVEMP. The right and the left ears are very similar. You'll note that the thresholds are both 95 decibels. The amplitude was slightly increased on the right, 60 as compared to 40. And then the latency was overall similar with a slightly increased latency on the right. Overall, the amplitude asymmetry ratio was 21%, which is below that 40%, which is considered to be abnormal. We also obtained some imaging as part of our initial diagnostic workup for this patient. What you see here is an axial CT image of the temporal bone. And specifically, I want you to focus in on the right side and the labyrinthine and tympanic segments of the facial nerve. What you see is an expanse-style lesion around the geniculate ganglion. This is a close-up of that previous slide, again showing that expanse-style lesion around the geniculate ganglion. And then on coronal imaging of that CT temporal bone, what you see here is the labyrinthine segment of the facial nerve in direct continuity with the middle and basal turn of the cochlea. So normally there's a bony partition there, which is just non-absent, which gave us quite a bit of suspicion for this being the etiology of this patient's symptoms. We also obtained MRI imaging. What you see here, these are T1 images. On the left is a pre-contrast image. On the right is a post-contrast. These are both axial images. And the blue arrow denotes both the labyrinthine and the tympanic segment of the facial nerves. And you can see that there's asymmetric enhancement with the administration of contrast. This is a coronal T1 image, post-contrast, again, just highlighting that asymmetric enhancement of the labyrinthine and tympanic segments of the facial nerve. So at this point, our differential diagnosis obviously was very broad. Things we were thinking about include, geniculate ganglion hemangioma, a facial nerve schwannoma, the broad category of otic capsule dehiscence syndrome, of which cochlear facial nerve dehiscence is one of those etiologies, persistent neuritis of the facial nerve, meningioma, cholesteatoma, or some sort of bony breakdown in the labyrinth due to something strange like syphilis or other infectious etiology. And just wanted to highlight, another topic in just a little more detail here about cochlear facial nerve dehiscence causing third window symptoms. So just a little bit of background. This was first described by Jung and authors in 2014, so it's a relatively new thing that we're talking about in this realm. They presented 2 cases initially, but essentially it's that mobile third window that causes alterations in the audiovestibular physiology. The incidence rates are quite variable based on if you're doing histology versus imaging studies, anywhere from 0.6% up to 9.2%. But just the biggest take-home point is though, even though you may see this on a CT scan, you really do need to correlate with symptoms that the patient is having. So we have a 60-year-old male with debilitating third window symptoms, but intact hearing and facial nerve function. The CT and MRI are suggestive of a facial nerve neoplasm causing cochlear facial nerve dehiscence. And the question that I would just like to pose to all of you out there in the audience is just, how would you manage this patient? So just take, a couple moments to think before we move on to the next slide. What would be your next step, or what would you propose to treat this patient? So what we'll go ahead and do is we'll watch this video here, but what we ended up doing is performing a round window reinforcement procedure. And it should play here. There we go. And what you see here is an endoscopic approach transcanal to the middle ear and round window niche. We have elevated a tympanomeatal flap. We previously harvested both tragal perichondrium and cartilage. And we are packing the round window niche with perichondrium first. And then just gently putting that in place. Then we're adding another layer of that cartilage, packing the middle ear with gel foam, and then laying back down that tympanomeatal flap. So how did the patient do post-operatively? That's the question of the hour here. So we saw him at both 3 weeks and then at 6 weeks. At 6 weeks, we obtained an audiogram, which you see here, and that was great news that his hearing was preserved, very similar to before. And that we did see an improvement in his dizziness handicap index going from 60 to 48. And then his most bothersome complaint was that otophony, which he reported was drastically improved. He did complain of some intermittent oral fullness and still some auricular pain, which were bothersome to him. So just to conclude, Third window symptoms in the absence of superior semicircular canal dehiscence should prompt the clinician to think of other etiologies such as cochlea-facial nerve dehiscence. Cochlea-facial nerve dehiscence in the setting of a facial nerve schwannoma is a very unique clinical situation that requires some high-level thinking. And round window reinforcement is a very reasonable treatment option for these patients because it does not compromise hearing or facial nerve function. And then just want to highlight some of the references that we used just through this thought process and in order to create this presentation. As you see, this first reference here is a great case series by Wakeham and authors that highlights the use of this round window reinforcement for patients with cochlea-facial nerve dehiscence. And then just a few more references on the next slide here. Just want to say thank you for this opportunity, and we'll take some questions later.
Thank you, Dr. Johnson. I think we will take our first Q&A session now. We'll try and get Dr. Amir Sagar back at the end. Please post questions in the chat. I'm sorry, in the Q&A section. I don't see any coming in, so I'll pose a couple of questions myself if I can take that liberty. First, for Dr. Fisher, what was the nature of the service member's blast injury that started his symptoms? And do you think there was a pressure wave going through the skull, or was it through the tympanic membrane, ossicular chain, and oval window?
Yes, sir. Thank you for the question. It's hard to say exactly. He didn't have any history of, so when we looked at mouse models previously, and studies have looked at this before, looking at the nature of blast injuries, frequently there's associated a TM rupture with it, indicating a direct transmission of pressure and energy through the ossicular chain through the cochlea with direct cochlear damage. He didn't have, in this case, a history of perforation of the ear to indicate direct ossicular discontinuity or any actual injuries there. So it may have been traveling through the skull itself and through the soft tissues of the brain, which contributed to some of that. His timeline was sort of interesting as well. He didn't have an immediate blast and sudden development of vertigo. He did have a delay of onset between those symptoms as well. And then he found that his vertigo was progressive over time. So it's hard to say. It's an interesting correlation between the two, and I do think it's a contributing factor to his overall presentation, especially given the fact that he had multiple severely thinned canal areas of dehiscence. But it's hard to say the exact nature of which one exactly caused it.
Thank you.
We have a question for Dr. Johnson on the facial neoplasm causing cochlear facial dehiscence. What is the mechanism by which you think the round window plugging improved the symptoms? And then I'll have a question for you as well.
So the thought process, my understanding of it at least, is that when you have three windows, there's this alteration in the wave, that the wave energy is just traveling through the cochlea and the labyrinth. So when you plug the round window, the thought process is you go back to that two window state, which creates a more normal physiology that you see if you don't have that mobile window. And then that leads to the improvement in symptoms is my understanding.
Just a comment for you. I think the way you handled the case was a very reasonable way to handle it. And the first time I ever did one of the window reinforcements is over 20 years ago. And one of the observations I've made is that the vast majority of them will get better. But if you don't do something to reduce the pressure being transmitted at the dehiscence site, eventually they're going to have a recurrence of symptoms. So one other option that you may want to add as far as a treatment is something to reduce cranial pressure for that patient. Especially, it may prolong the success of your surgery because my experience has been a large number of these folks will recur within a year or two's time.
Gotcha. Are you talking medical management with something like acetazolamide or?
Yes.
Okay, perfect.
Yeah.
And if I could just follow up on that, Dr. Johnson, could you tell from the CT, was the dehiscence into scala tympani, or did it did it span and also include scale of vestibuli?
On the CT scan, I'd have to look back to be 100% sure to answer your question. On that coronal image, it seemed like that entire bony partition was broken down. We had our neuroradiologist review the scan. So I believe it was impacting both, but I would have to look a little bit closer and chat with him as well.
Because it might be interesting to model the different effects you might expect from a window there. Plugging the round window is probably different for a distance into one of those scala than it is when it's way down distally in the vestibule. I think we probably need to move on and start our next set. And hopefully we can maybe get Dr. Mirzagar in at the end. So next up, we'll have Dr. Zachary Schwam present on exoscopic approach to middle fossa repair of superior canal dehiscence.
Okay, thank you very much. I'd like to thank the ANS and my co-authors for giving me the opportunity to present our data. I'm the fellow at the Icahn School of Medicine at Mount Sinai, and I'll be discussing the exoscopic approach to middle fossa repair of superior semicircular canal dehiscence. So to give a little bit of background, the exoscope or extracorporeal video telescope is a robotic microscope that's suspended above the surgical field with a number of theoretical advantages. At long focal lengths, it has relatively long focal lengths, enabling it to sit pretty far above the field while providing a high definition 2-dimensional or 3-dimensional view on a very large screen. You can pretty seamlessly incorporate navigation, which is also available on higher end, newer microscopes. It's theoretically less bulky and can also allow for more natural surgeon posture, and everybody in the room, from trainees to assistants, has the same view. There are, however, a number of disadvantages, perhaps, including loss of depth perception in the 2D models or the need to wear 3D glasses if using the 3D version. It can be difficult to maneuver. At high brightness, you can have a little bit of washout of color. You can have pixelation at higher magnification. It may be difficult to use in relatively tight corridors, such as skull-base surgery. Its use has been steadily increasing in otology and neurotology. It's been recently described for use in laryngoplasty, T-plasty, CI. We described a case a few years ago of a middle fossa transmastoid encephalocele repair, and it's been used in multiple and a variety of lateral skull-base procedures. This is just a intra-op photo of the case we'll be discussing. So we've got Dr. Perez, the attending surgeon, here with the robotic exoscope kind of perched over his right shoulder. You can see little fiducials, little glion fiducials that are attached to the exoscope that will provide the navigation references. And the exoscope is draped just like a regular microscope. From the surgeon's perspective, you've got two very large screens perched a few feet away from you. You've got the operative screen on the left, the navigation screen on the right, and the line of sight eye, the infrared eye above the two screens. Very similar perspective. We have the microscope in the corner just in case. And in the attending surgeon's right hand, there's a navigation wand. So we had two patients with debilitating third window symptoms, including sound and pressure-induced vertigo, found to have superior semicircular canal dehiscence, who both underwent a middle fossa approach to plugging and resurfacing of the canal with bone pate, wax, Surgicel, temporalis fascia, and a split calvarial graft. For both cases, we used the Synaptive Modus 5 exoscope. A nice point that I'd like to bring up is that we were able to, obviously find the defect on a preoperative CAT scan and then set a trajectory preoperatively. And And then during the case, you're able to see whether or not you're on the correct trajectory. That circle in the top left pane will turn green when you're on the right course and red when you're a little bit off. Just to talk about the incorporated navigation, at one point during the case, we were pretty sure that we had found the area of dehiscence, but because the skull base was pretty diffusely ratty, we put the pointer in a couple of different spots, and here you can tell we're clearly not over the area of the superior semicircular canal. So this is a video that'll hopefully start playing. This is the 2D version. So we're plugging the dehiscence with bone pate and wax. And we're looking at the 2D. We were using the 3D version, but assuming everyone's not wearing 3D glasses, I figured this would be more appropriate. So we've got a lot of bone pate and wax. We're resurfacing kind of the whole middle fossa floor here, in addition to the focal area of dehiscence. We'll place a big piece of temporalis fascia over it. We'll put a split calvarial graft on top, and then we'll take the retractor out, and that's how it looks at final appearance. So in terms of results, our two patients, patient 1 had a improvement in the PTA from 17.5 to 11.25. There was preoperative asymmetry in the OVEMP, but unfortunately the patient has not gotten their post-op O and C VEMPs. Yet patient number 2 had a big improvement in the audio in terms of PTA from 36.25 to 13.75. And we see a clear reversal of CVEMP amplitude asymmetries from 59 to 2%. Unfortunately, they couldn't do the OVEMPs due to fatigue. And in both cases, their symptomatology improved drastically. So just a brief discussion here. So we were able to find, so the interesting part of the case is not necessarily the repair, but the fact that we use the exoscope in a different method of visualization. So we found that it provided excellent optical quality, but there were a lot of adjustments that we had to make with respect to proprioception, depth perception, and viewing the screens at a sufficient distance away. We found it useful to incorporate the navigation and to set a trajectory. We did not need to convert to the microscope because the corridor was small, and because the corridor was small, having the exoscope over your shoulder at times was relatively awkward. And we also found we had a little bit of difficulty maneuvering the machine manually, and we found robotic repositioning to be pretty tedious. And because of all the equipment that goes with it, you really need the company representative present. Thank you.
Thank you, Dr. Kwon, for an excellent presentation. And for our next presentation, we're going to have Dr. Eric Formeister. He is going to present the revision of a transmastoid repair of superior canal dehiscence with simultaneous cochlear implantation. I think you have to unmute yourself, Dr. Formeister.
Good afternoon, everyone. My name is Eric Formeister. I'm the second-year neurotology fellow at Johns Hopkins. Thanks to the ANS for allowing me to present this case at the third Mobile Window Study Group, and thanks to Dr. Dellasantino for his wall of fame behind me. So we have no disclosures relative to this discussion. So the case presentation, this is a 23-year-old gentleman who had actually bilateral superior canal dehiscence, a left tegment dehiscence with an associated encephalocele but no CSF leak, who had presented to an outside institution with autophony and sound-induced vertigo. He underwent a combined left transmastoid and middle fossa craniotomy for repair at an outside institution. And per the operative notes, this was actually a cartilage capping procedure via the middle fossa. And unfortunately, he awoke in the PACU with profound sensorineural hearing loss and vertigo and a persistence of his symptoms. And he actually went on to develop sort of progressive symptoms, including a CSF leak, at which time a CT scan actually revealed pneumocephalus with compression of the temporal lobe. And this required a revision left transmastoid and middle fossa craniotomy with plugging this time via the middle fossa with fascia. So when he presented to us, he still had persistent autophony on the right side from his right canal dehiscence, as well as sound-induced vertigo and pressure-induced vertigo localized to the left. On exam, he didn't have any evidence of superior canal hypofunction, consistent with incomplete plugging of that canal, but he did have a positive Tullio's phenomenon on the left. OVEMs were in normal range bilaterally, and a CT scan, which I'll show in the next slide, showed a persistent left superior canal dehiscence. And the audio showed a left profound sensorineural loss with sort of the pattern that you would expect for a right superior canal dehiscence, which I'll show. So on the left side of the screen here, it's the standard postural view CT scan reformat showing large segment dehiscence of that left superior canal. And on the right panel, it's just the orthogonal view showing just the orthogonal view of the same canal dehiscence. And then the long arrow is pointing to some bone cement that had been used previously for repair. Now, one caveat is we know from revision cases that CTs aren't great at showing cartilage. So whether or not this was actually present is not entirely clear, but given his persistent symptoms and the findings, objective findings, when he presented to us, we talked to him about a revision repair. Here's his audiogram, again, showing left-sided profound sensorineural hearing loss, and then this right-sided negative bone line to the mild low-frequency conductive hearing loss, classic for SCD. So we talked to him about doing a revision transmastoid plugging at the same time that we perform a single-sided deafness cochlear implant. And interesting to hear people's thoughts about this now that the FDA has approved this within the last 2 years, if others have similar cases. But to do the revision transmastoid underwater plugging, so we standardly do a big mastoidectomy cavity, and then we try not to saucerize so that we can create a sort of a bathtub which will hold BSS. And once we've identified and blue line the superior canal, we fill it with BSS and then we use endoscopes to perform the plugging of the canal underwater. We just think that the BSS is more physiologically appropriate to prevent any delayed onset of inner ear inflammation. So we'll do this and we'll perform 2 canalotomies that we believe, based on image guidance, are anterior and posterior to the presumed dehiscence. And we standardly plug with fascia, bone dust, bone chips, and then resurface with bone cement. At the same time, we did notice residual CSF leak from arachnoid granulations through that same tegment defect that had been encountered in the first surgery. After plugging the canal, we then performed a facial recess approach to identify the round window niche, which was actually completely obliterated by dense fibrotic scar tissue. So this had to be sharply incised, and we actually had to do a little bit of a basal turn drill out of about 4 to 5 millimeters. And then we like to use 2O nylon for cases of dense scar tissue, cochlear otosclerosis, for example, or other meningitic changes for people getting a CI. And we use a 2O nylon to sort of sound it and create a tract for the implant. And eventually we were able to fully insert the MED-Flex 28 with little resistance, and an X-ray showed proper positioning and no kinking or fold over. And then at the end of the case, we ended up using a fat graft to seal off the facial recess, the mastoid, and then just seal it all up and close it up. And he was admitted postoperatively, and we always check on post-op day 1 if the head thrust shows expected superior canal hypofunction, and it did. It didn't show any horizontal or posterior canal hypofunction, which is occasional in the case of a pan canal inflammation. He did report resolution of sound-induced vertigo. He was happy about that and underwent vestibular PT and was discharged on post-op day 2. And his 6-month audio, shown on the right, just shows that he has good sound awareness with his CI, and his word rec score is 96%. So some discussion points. So I thought this case was more interesting for the discussion points that it raises. So first is just to drive home the point that there is mild high-frequency hearing loss in about a quarter of patients undergoing middle fossa craniotomy for superior canal dehiscence repair. Fortunately, the profound sensorineural hearing loss is much less common, and we don't think that it matters based on the approach, although more recent data that we're collecting is showing that probably underwater repair is a little bit better for maintaining a physiologic environment to perform the plugging. And then a CI after opening the labyrinth is feasible. We know this from delayed cases for single-sided deafness for Meniere's disease patients who've had labyrinthectomies, but it's a good idea to anticipate a heavy scar burden and to use a sounding device to try to open it up. And then potentially use a T2-weighted MRI, which can assess for a nice fluid signal into which you could place your implant. And just be prepared to potentially drill out some of the basal turn to allow for definitive implantation with, of course, an intraoperative X-ray. So that, I'd like to thank everyone. And again, thank the ANS for allowing me to present this case. Looking forward to any questions.
Now, thank you. Great presentation. We're going to try now to get Dr. Amir Zagar back on. His presentation is on prevalence of otic capsule dehiscence on CT. And I think he's muted. We're trying to get him some feedback that he's muted. While we're doing that, this is a good time to put some questions, comments in the Q&A section. We are forwarding those to our speakers so that they can be prepared to give you answers. If it looks like this is not going to work, we can go ahead and go to our discussion. We'll give it another few seconds here.
Can you hear me?
Yes. Please present.
Yeah. No, I can hear you. Yeah. Manage.
Have your audio now.
Yeah. Yeah, of course.
We found there's a significant time delay for his audio, so I think Neil is working with them to get that going. If it's not going to work, we can record this and make it available to you afterwards.
Hi, everybody. Can you hear me? Hi, everybody.
Apologies for the technical difficulties. We are trying to get Behruz in. Behruz, if you can hear us, please go ahead and speak.
Yeah.
We can hear you.
Yeah. Hello, everybody, and I'm sorry for there is a problem with my internet, and I try to figure out it. I'm Dr. Amir Zargar, Assistant Professor of Otology and Neurotology at Tehran University of Medical Science, and I'm going to present the result of a study entitled Prevalence of Otic Capsule Dehiscence on Temporal Bone CT Scan. Next, please. As you all know, following the first report of dehiscence in superior semicircular canal by Minor et al. In 1998, numerous dehiscence of otic capsule were described, such as posterior semicircular canal dehiscence, dehiscence between the cochlea and internal carotid artery, between the cochlea and internal auditory canal, between the cochlea and facial nerve, and also between the jugular bulb and posterior semicircular canal or vestibular aqueduct. Different study reported different type of otic capsule and different prevalence, and we aim to determine the radiologic prevalence of otic capsule dehiscence on temporal bone CT scan in our population. This was a cross-sectional study, temporal bone of 600 patients were from our archives of temporal bone in our tertiary referral hospital were included in this study. Patient who underwent surgery, any portion of otic capsule, for example, labyrinthectomy or tumors involving the otic capsule, and traumatic patient were excluded from our study. I can push the next button, but we use these CT scan devices. Images were obtained in the axial and coronal plane with multiple reformats using a slice thickness of 0.6 to 5 millimeter. When at least we use at least 3 plane with specific type of reconstruction for each type of otic capsule. For example, for superior semicircular canal dehiscence, images were reformatted in the plane of Portial or Steinberg. When a dehiscence was present in at least 2 consecutive images in all 3 planes, we consider it as a true dehiscence. Then all the images were confirmed by a trained academic radiologist. Our population was 600 patients or 1,200 years. Mean age of patient was 40, from 1 month to 81 years old. The prevalence of superior semicircular canal dehiscence was 6%, posterior semicircular canal dehiscence was 2.7%, and there is no lateral semicircular canal dehiscence in our study, but we have 2.8% lateral semicircular canal dehiscence secondary to cholesteatoma. We classified primary superior semicircular canal dehiscence into two categories: superior semicircular canal dehiscence not related to superior petrosal sinus, and when it was secondary to superior petrosal sinus pathway. If you can see the slide, you can see the pathway of superior petrosal sinus through the superior canal. In this table, you can see the prevalence of in this table, you can see the prevalence of semicircular canal dehiscence, and also if you can see most cochleofacial dehiscency were only on the left side, and most vestibular aqueduct jugular bulb dehiscency were on the right side. And it was in the setting of high jugular bulb. Next slide, please. In our study, there was no significant difference between two gender in prevalence of otic capsule dehiscence, and among different age group, posterior semicircular canal dehiscence was more common in 5-year-olds or younger patients. But there was no significant difference among different age group in other type of otic capsule dehiscence. As a conclusion, our study demonstrated the prevalence of otic capsule dehiscence in our population, and considering different type of otic capsule dehiscence which described, care should be taken to the patient with pulsatile tinnitus and other vestibular and auditory sign and symptom to diagnose this dehiscence. Thank you for your attention. I'm sorry for the internet that
Thank you, Dr. Armazaga. I thought that was a very fascinating presentation. Issues. We're now going to move into a discussion section for the cases that have been presented. And the first, a comment and question for Dr. Schwalm regarding the exoscopic approach. First, Dr. Schwalm presented that once the operative team is familiar with the setup, the rep is no longer needed, and they've been using it for 4 to 5 years. Someone asked, how long did the exoscopic procedure take? Also, add to that, once you guys were familiar with its setup and use, what is there additional setup time as opposed to a traditional approach?
So I don't have the exact timing as to how long everything took. I would say it took, the actual operative part took about the same as it takes us for the normal microscopic approach. I would say most of the setup kind of takes place in parallel with the craniotomy. So as the neurosurgery team is kind of doing the approach in the crania, the rep in our hospital typically sets up the screens and whatnot once, and then once the crania is open and we're ready to patch and resurface and plug, generally ready to go.
I think our next question, Dr. Porter, with the loss of hearing and preserved vestibular function and scarring within the cochlea, does that suggest anything about the mechanism of the hearing loss here? And I guess the follow-up question would be, what is the time lag from the time of the hearing loss to the time of your procedure with the cochlear implant?
It's a great question. I was thinking about this yesterday when I was going back over the old operative reports. All I can say is that in our experience, longer dehiscences that are open for a longer period of time are likelier to have a pan-canal hypofunction on post-op day 1. So we think that there's some type of inner ear inflammation that typically resolves over time. And I think Dr. Agarwal actually did a nice paper that showed that even there's an increase by 2 to 3-fold in the likelihood of pan hypofunction with each 1.5 millimeter increase in the length of dehiscence. Why that might have, so to me, if he had immediate post-op vertigo, I would expect that he probably had pan hypofunction at that time, and then that resolved, but why the hearing didn't, I don't have a good explanation for that. I think that was Dr. Buckman's question. And then to follow up on Dr. Sharon's question, yeah, it's a great question. With that degree of scarring, I don't think that was necessarily anticipated based on the history, but he did have a CSF leak that was occurring for some unknown period of time that we don't have that data necessarily, and then developed pneumocephalus. So he clearly had wide opening between his middle ear space and his middle cranial fossa. So even if I don't believe he had a history of bacterial meningitis, but if there was some type of just chemical meningitis or chronic irritation from a prolonged sort of indolent CSF leak and a big tegment defect and residual arachnoid granulation, I don't know if that could have accounted for a meningitis type picture where the cochlea ossifies or fibrosis the way that it did in this case. That's I guess my best explanation for that.
Again, do you remember how long it was from the time of his hearing loss to the time of your procedure?
Oh, sorry. Yeah, that was at least a year from the time of his procedure to ours. I think it was like 12 or 13 months.
Yeah, if I could comment, this was a case that I did with Eric and Charlie Della Santina did the cochlear implant. Yeah, it's maddening that why is the vestibular function preserved and the hearing lost? I think there's a degree of atelectasis that happens when perilymph is lost from a big dehiscence at the time of surgery. I think that the vestibular system is more likely to recover from that than the cochlea is. And we commonly see cases that with large dehiscences, global hypofunction in that labyrinth, and Eric referenced the paper Yuri Agarwal wrote. But that usually resolves after 6 weeks when we check them quantitatively. So I think the vestibular system has more recovery capacity than the cochlea. We had a question from Dr. Brookler more generally for the panel, and anybody can take a shot at this. Any idea of the etiology of dehiscences aside from an expanding lesion? Jerry, I know you've written some on this about the possible relationship of intracranial hypertension to the development of a dehiscence.
Well, I think it's different for different groups. I think probably the majority, I go back to your study, John, where there was identification on histology of early on in childhood that eventually closed, but some of them persist. So that I think my suspicion is that the majority are developmental, but I've certainly seen cases that are obviously acquired, cases with arachnoid granulations into the canal, or actually even one where there was just a tiny fracture over a small, a thin dehiscent site. There has been a lot of literature coming out on intracranial pressure causing thinning of the bones, and I suspect that is an etiology in those cases with thin bone to begin with.
Yeah, I think what we don't really have a handle on is what happens with the dura over time. We see so many of these individuals who have pretty obvious dehiscence on CT, and their ears are asymptomatic. They have no conductive hearing loss. Their vents are normal. I think that in many cases the dura remains relatively inelastic, and I think that the intracranial pressure changes. For example, the blast injury that we heard in the first half of the presentations today I think that it's a pressure wave that's probably mobilizing that dura enough to start pressure transmission.
I was going to say, I think that makes a lot. That actually brings up a question I wanted to ask Dr. Armazarga. In his series of patients who had gotten scanned, both what was the reason for the scan, and did any of them have any kind of third window symptoms at all, or is that just data they don't have? Are you with us, Dr. Armazarga? I know there's a audio train.
I can comment some more about that because we've recently looked at that. It is interesting, the idea of increased intracranial pressure, obesity, obstructive sleep apnea, things like that. I think it's kind of controversial if that predisposes to a superior canal dehiscence. We know that certainly that predisposes to Tegman dehiscences and encephalocele and spontaneous CSF otorrhea, but at least in our series and some others, these patients tend not to be sort of the obese population. They tend to be sort of 40s to 50s, in our highly selected population just here anyways. But in terms of the intraoperative Tegman dehiscences that you find versus what's called on CT scan, that's actually pretty different. We went back and looked at that as well. And in general, the CTs, overcall dehiscences, and they overcall Tegman dehiscences as well. So I think there's no doubt there's a higher likelihood of overall lateral temporal bone attenuation in superior canal dehiscence, but I think it's hard to definitively call unless there's clearly dura pushing down onto the ossicles a Tegman dehiscence on just a radiograph alone.
Well, I think we have just about almost over our time. If there's any other questions from anyone else, or any other comments from the presenters.
I want to thank everybody. I think this was a great session. This is our second third mobile window group. We look forward to doing this in person one day. We're glad we could get it started during the pandemic, and we hope you enjoyed this. I know Jerry and I enjoyed putting these together for you, and we look forward to a successful rest of the meeting. Congratulations, Dr. Buckman.
Thanks, guys. Good job.
Bye, everyone. Remember to go back to the agenda and pick the next session.